So, in your books, in the front of my lecture, I've also included the paper that's just been published by Weingart again. So Weingart did the apneic oxygenation. He was also pivotal in this stuff on delayed sequence intubation. And the paper's in there, plus also a copy of a blog that I wrote, a couple of other things. So it's just something for you to read down the track. Real quick lecture. Delayed sequence intubation is a new term, and it's basically procedural sedation, where the procedure is you oxygenating the patient. That's all it is. Okay? It's sedating them to allow you to oxygenate the patient. And it came forth from a group of patients that may be the agitated patient. Who here has ever tried to put a BiPAP mask on a patient with APO or COPD or something, and you kind of, and you know, they come in and go, I can't breathe, and you go, that's right, put the mask straight on you, right? And do they fight you? For life, of course. You're muffling them like putting a pillow on their face, right? Well, we've come up with a technique where we're going to take that fight out of you. We're going to give you this drug so you can't fight, and then we're going to oxygenate you. That's this whole premise, and it works. Okay, and that's the important thing. Who's it for? Patients that aren't obtunded. They've got to be able to breathe, and in whom there is difficulty oxygenating. And ketamine is the drug. Okay, ketamine's very quickly becoming the new magnesium. You know, and a few years ago, although this drug actually works, unlike magnesium. So a few years ago, I poo-pooed magnesium at a conference that I did. And I showed some spectacular slides of me filling up my car with magnesium now. I shampoo with magnesium. We're now actually bringing out magnesium product that allows men to be more virile than they've ever been before. You can use it for anything. They've tried it for everything, all right? You know, eclampsia and torsades, maybe it works. Not much good at anything else, I don't reckon anyway. But ketamine is spectacular. You can shampoo with ketamine. You can. Ketamine is spectacular. And I don't know I can't remember whether I've included a slide on asthma in here, but if I have, I'll talk about it. So this is about apneic oxygenation. That's why we swapped the lectures around. They'd make more sense this way, plus something, plus some other form of oxygenation. Bag valve mask with PEEP. Your patient's got to be able to breathe, as he said, or CPAP or something else for you to get that increased oxygenation in there. And the patients that we want to oxygenate up, you might have to use a bit of positive pressure to get them in there with the bag. So this was originally what people want to do, pre-oxygenate them, induction paralysis, and then you intubate, okay? Whereas the new approach now, different slide. Anyway, all right. The new approach now says let's dissociate them with ketamine, and which is like an induction, but not as much of an induction dose as we normally give. Let's pre-oxygenate them. Let's get them pre-oxygenated, put in the apneic oxygenation, and paralyse them, and then tube them. So it becomes more like this down the bottom. So the apneic oxygenation, for my money, stays on throughout just about all of this, and then you do whatever else you have to add on top to oxygenate these patients. So ketamine is a step where we just sedate them a little bit in order to allow us to oxygenate them. And we could be surprised that some of these patients don't need to then be intubated, because once they've stopped fighting you and they relax and you increase their SATs, you might actually find that some of them don't need to be intubated. So pre-oxygenation becomes very important, as Luke was saying, because it buys us time. And why it's important, and we're talking about oxygen dissociation, we're talking about saturations, is that when you're sitting at about 93%, your PaO2 is sort of starting to go down to 60 and below. Once you turn this point, and you use the roller coaster example, once you turn this point and you start going down this slippery, slidey slope of death, those O2s, the PaO2 drops significantly. You're trying to catch up once you're at this point. And catching up becomes very, very difficult. That's why it looks like a roller coaster. It's hard to stop that roller coaster as it's coming down. It's easier to stop it as it reaches that peak, and once it starts flying down, it picks up momentum. All that potential energy goes to kinetic. You could have a special roller coaster too. That's not real. That's not real. That doesn't exist. That's a bit of manipulation of the video. Right, so... Because I know my daughter would have said, "I've got to go there, Dad." So that's what it looks like, 93%. If you don't have that, this is what happens. You drop off, you can't pick up. So oxygenating these patients becomes really important. And this is a study that you've got. 62 patients, they had, some of them needed this sort of sedation for non-invasive positive pressure, non-rebreathers. Some of them needed just nasogastric tubes and all sorts of things. But they found that their SATs increased, all of them pretty much, to greater than 93%. And this is the drug. Ketamine was used. They used a 1 milligram per kilogram slow bolus. If you give it fast, it can cause apnea, so they gave it slowly, okay, over a couple of minutes. You can actually start a little bit lower than that. You can start at 0.5 if you want to. They used 1 and they went up by increments of 0.5. And they then oxygenated the patients as hard as they possibly could. They used apneic oxygenation on all of these patients, and they could awaken or intubate them. There are some cons to this study, and you can look at it yourself and read it. It wasn't randomised. We don't know what could have happened if delayed sequence intubation wasn't used. There is some selection bias because the patient chosen for this was chosen by the clinician, and it was in a centre where the clinicians were extremely well versed at using this drug. So we don't know. But the indication is that this is really good, okay? And having used this, it's really good, okay? So, but we don't have randomised controlled trials yet. What's interesting in this study, and you don't have to read all, down the bottom here, 2 patients didn't need intubation in the end. Their oxygenation improved so much with this technique, so they were sedated with ketamine, oxygenated up really well, and then they found that they didn't need to progress to intubation because the patient improved and they allowed them to wake up. What's good about ketamine? It puts you in a dissociative state, but it maintains your airway reflexes, okay? So you protect your airway still with it, unless you give them a massive dose and they stop breathing. So that's why they gave them a small dose slowly, 1 milligram per kilogram. I usually give 1 to 2 milligrams total to intubate with it. I usually start at 0.5 if I'm sedating or if I'm doing this and I build it up to 1. I go even slower than this. But it dissociates you without taking away your airway reflexes. That's the key. And if we look at all of their patients in their study, the blue is where they were in terms of oxygen saturations, and the red is where they ended up. Significant improvements. There are a couple of patients that didn't do well. These guys had some shunts, etc. But most of these patients, their saturations went up. Okay, this is significant stuff. So how to do it? You try to pre-oxygenate. If it's not working, you consider ketamine. In the study, they used 1. I sort of say 0.5 to 1. You can make up your own mind, milligrams per kilogram. This is in adult patients we're talking about. Increase it by 0.5 milligrams per kilogram. Slow push. Apply a non-rebreather or whatever you're going to use. And then with apneic oxygenation, you've still got to use Luke's technique because it'll buy you time. Okay? And I can tell you it works very well. And I use it on every sedation. I use it on every intubation, okay? And it buys you time. And in a difficult intubation where it hits the fan, this is a really good technique. And on Luke's technique, this apneic oxygen, I had a patient, I sedated him, I needed to intubate him, I couldn't tube this patient, right? And this was a few months ago. This was the second time in my career I've had one that you go, what the hell am I going to do? Okay? 6 minutes. He stayed at 100%. His CO2 is going to rise because he's not ventilating, right? That's all right, we'll blow that off. But his SATs were 100% We tubed him, he was fine, he was discharged home a week later after all what had to be done. But it's important to use apneic oxygenation. If your patient is fighting you, you might use this technique to oxygenate them up, and you might get away without intubating them. Oh, I did put it in. Something to think about in asthma. Does ketamine work in asthma? We used to sort of say don't use ketamine to intubate asthmatics and all that. My view is I use ketamine as my drug of choice. It causes bronchodilation. It can cause increased secretions, but I don't really care. Once I've tubed them, I can suction them. All right? What's interesting is there's two studies. There are two major studies that have come out in the literature. One was in 1996 and one was in 2005. And the two studies actually showed, the one in 1996 showed that ketamine was no better than placebo, and the one in 2005 showed that ketamine was no better than using normal therapy. Having said that, though, all the case studies are showing that bronchodilation does occur with ketamine, and patients on asthma, if you give them a little bit of ketamine and put them on a gentle infusion, do better. The difference between these studies and what we do is that they use very low doses. They use 0.2 milligrams per kilogram. We start at 0.5, okay? Their patients did not go into any sort of dissociative state. So they still had that angst and all the drive that occurs. We take that away with the ketamine, and we can oxygenate them up. So that's very, very important. So delayed sequence intubation is a process where you're going to use apneic oxygenation, but what you're going to do is you're going to have one step before you give them the paralysis. You're going to give them ketamine at 0.5 to 1 milligram, slow. You can repeat the dose of 0.5 milligrams. Once they're in a dissociative state, it gives you the ability to put that mask on them. It gives you the ability to oxygenate them up significantly, and then you can proceed to paralysis and intubation or not, depending on what your patient does. Okay? Any questions? We've got a couple of minutes. Any questions? The technique is very simple. Yes? Who can't you give ketamine to? So there's only one group, really. Who can't you give ketamine to? How about raising the cranial pressure? No evidence, right? So there is one group, and the group that I don't give it to is the hypertensives or the preeclamptics. Now, the hypertensives that have potentially got something going on there, I'm not going to give it to. Because if I make them more hypertensive, which is a potential thing that ketamine can do, it can make you hyper or hypotensive, but it's usually a very stable drug and raises your blood pressure rather than lowers it. In those patients, I can increase their intracranial pressure if I think there's something going on in the head. But you're not going to use this on everybody. You're going to use this on the patients that you can use ketamine on. So you're not going to use it in your hypertensive patient that's potentially got raised intracranial pressure, and if you peak that blood pressure, you might make it worse. And you're not going to use it on preeclamptic type patients. But everybody else, free slather. Yeah? Yes?
You say slow, but how slow?
Oh, a minute or so. Yeah. What I don't want you to do is, yeah. So a minute to two, just nice and gently, just pop this thing in. Usually it occurs. Usually I say a minute or two, but it's still about 30 seconds when I do it. I kind of lose patience and just push the last bit in.
Got a question at the back here. I'll just have that there.
Get the mic up there. Still got a minute on my time. We can use that time.
Should you still use the ketamine as the induction agent for your intubation, or can you use anything still?
Yeah,
after?
I use it, yeah. I use it, and I think Jason will talk about rock, but I believe standard of care now is ketamine and rock uranium.
Anyone else while I'm up here and wandering around?
I still use propofol sometimes, but I think ketamine for me is a very stable drug. And so if you're going to use propofol, for example, you might drop their blood pressure, all sorts of things might happen. If you use ketamine, ketamine is like the etomidate that the Americans or the New Zealanders use. However, it doesn't have those adrenal suppression effects that etomidate has. It's effectively quite a safe drug, and it has bronchodilation effects. It has all of these benefits to it. So you're giving something that doesn't drop their blood pressure, keeps them stable, dissociates them, they maintain reflexes. You can even have a quick little look in if you wanted to, because they maintain their reflexes, right? So you're not everything's going to collapse. And then you decide this is pretty cool. You paralyse them, and I paralyse them with rock uranium rather than sucks, and then I do my tube. So for me, it's standard of care now.